Good afternoon, everyone. Welcome to the HRSA and Social Solutions International webinar looking at intimate partner violence and perinatal depression. Before we begin, I just wanted to take a minute to review a couple features that we'll be using during this and future webinars in case you haven't used this system before. There's two main features that we'll be using, and they're in this diagram. So one looks like a little raised hand, and you can click on that and it will alert me that you have something to ask or comment on. We'll be using this feature towards the end of the webinar in case you have questions or comments. And we'll try to go in order and get to everyone with time permitting. There's also a little question chat feature that you can use. So you can type in questions or comments to us using this. We may not get to all of them on this log, but this saves the chats for us so we can go back and get back to you if you have any questions or comments. Again, my name is Kara Finley, and I work with Social Solutions International on the HRSA IPV PD Resource Development Project. Joining us, we also have Dr. Keisha Highsmith from HRSA's Division of Healthy Start and Perinatal Services, who leads this project. And then I'll be introducing our two guest speakers, Dr. Diana Chang and Ms. Ife Udo. Keisha, would you like to welcome them?
Yes, welcome everyone, and thank you, Kara. The Maternal Child Health Bureau is charged with a primary responsibility for promoting and improving the health of our nation's women, children, and their families. During the last decade, in support of this mission, the Division of Healthy Start and Perinatal Services, through demonstration grants, its Healthy Start program, and technical assistance contracts, has undertaken a series of initiatives designed to improve provider and community capacity in assessment, screening, and intervention for domestic and family violence, depression, and substance abuse during and around the perinatal period, and to promote positive health behaviors in women. The Bureau conducted a review of the findings, recommendations, and care models that emerged from these efforts and concluded that although public awareness has increased regarding the adverse maternal and child health outcomes associated with the intersection of perinatal depression and intimate partner violence, many pregnant and postpartum women with depression in conjunction with intimate partner violence may be identified by healthcare providers and consequently do not receive necessary interventions. Therefore, the Division of Healthy Start and Perinatal Services is leading this 3-year initiative called the State and Community Intimate Partner Violence and Perinatal Depression Resource Development Project. HRSA MCHB is working with Social Solutions International, Inc. and also Alterum Institute to, 1, develop resources that will serve as a guide that is culturally and linguistically appropriate to support community-based programs with making the case for why it's important to address the intimate partner violence and perinatal depression intersection, and 2, to support community-based efforts to prevent, assess, and refer women to appropriate services in their community. So at this time, I will turn it over to Kara Finley to review the objectives of today's webinar.
Thank you, Keisha. So today during the webinar, we'll be discussing the intersection and effects of intimate partner violence and perinatal depression. We'll look at IPV and PD screening a little bit, and then we'll introduce you to the toolkit that we are in the process of creating. Next, we'll move on into our guest speakers. Our first guest speaker is Dr. Diana Chang. She is a board-certified OBGYN and is currently the medical director of women's health at the Maryland Department of Health and Mental Hygiene. She's also a senior associate at the Johns Hopkins Bloomberg School of Public Health and is a member of ACOG's Committee on Healthcare for the Underserved. She received her medical degree from Johns Hopkins University School of Medicine and completed her residency in obstetrics and gynecology at Tufts University. Two of her primary areas of interest in women's health are depression and intimate partner violence. Dr. Chang?
Yes, great. I'm so delighted to be here. And first, I just really want to thank HRSA for having the insight to integrate depression and IPV into one topic, really. Because so often we actually work on only one topic or disorder at a time, and we lose sight of the fact that the conditions really overlap immensely, and one impacts the other. So I'm really delighted to be on this webinar. Let me get started with the first slide. Let me see if I can. Let's see. Do I have the ability to advance them myself?
You should. Can you click?
I did, and nothing's going on.
Okay, hold on.
Okay.
Excuse us. All right, I'll do it. There you go.
Okay. Okay, great. So I think it's important to first start with basic definitions so we all know what we're talking about and we're on the same page. And I'm going to start with perinatal depression. And how we define that is just basically general depression occurring during pregnancy or within the first postpartum year. And it's important to know what definition people are using when they're talking about postpartum depression or perinatal depression, because a lot of times they'll define it within the first 3 months after delivery or first 6 months, and it does change the prevalence and some of the impact of perinatal depression immensely. So the definition is very, very important. Next slide. And I want to also cover intimate partner violence. I think the definition there is also incredibly important and changing a little bit. It's a pattern of assaultive or coercive behaviors perpetrated by a current or former intimate partner. And I think the main things is that it has to incorporate 3 separate entities: the physical part, the emotional part, and the sexual part. And a lot of times we'll see that when you're looking at certain studies, they'll just say physical intimate partner violence, or they'll just do sexual assault. But really IPV is all 3 of them together. And it's also important to be very concrete, knowing what these entities entail. And when we say physical violence, it's pushing, shoving, scratching, grabbing, biting, strangling, slapping, punching, burning, hitting someone. It's any one of those. And sometimes women don't really answer yes to just, have you been physically abused? They almost have to hear some of those examples. It's important to just give them those examples too. The emotional abuse, I think, is the one that's mostly not talked about, not looked at, not really focused on at all. But it's really probably actually as important as the other 2. And by emotional abuse, we actually mean humiliating someone, calling them names, and controlling who or where they can go, on who they can see, embarrassing them, isolating from their friends or family, denying access to money or other resources, stalking them. And I think, in our modern days, we have even just some really electronic emotional violence by texting someone and insulting them that way, or just really, even instant messaging someone, and it can be very, very emotionally abusive. The third part is the sexual assault, and I think all those 3 are very, very important to consider. Next slide. So really, the overlap is very, very important, and we see that emotional abuse is really the biggest circle, the green one, but it really overlaps a lot with the physical abuse and with the sexual abuse. And there's not that many abusive situations where you only see one thing going on, or if you do see one thing, it sometimes can spread to, let's say, emotional abuse can actually very rapidly spread to sexual or physical abuse. And in some women, all 3 are going on simultaneously. So it's really one big picture. Next slide. This, I think, is the best study that I've seen, and it's come out very recently. I think it just came out a couple of months ago. And it's the National Intimate Partner and Sexual Violence Survey. I think the data was taken from 2010, the survey. And basically, we can see that in someone's lifetime, a female, 9% of females have been sexually assaulted, 33% have had physical violence, and 10.7% have been stalked, which is a form of emotional violence. And we also see that, any one of those 3 in a female's lifetime, they have a 36% chance of having had IPV. We also see the male part too, which I think has been really completely ignored, but they actually can be victims of IPV as well. The main thing I think is if you look at the bottom row there, the impact of IPV on other conditions, you can see that females really have much more IPV-related impact than males do. So, for instance, needing medical care, it's 7.9% for females versus 1.6% for males, and other things like PTSD in the future, being concerned for their safety, contracting STI, much more so for females than males. So even though you can see the incidence and prevalence of IPV is not that different for males versus females, I think the impact on females is tremendously different. And here we also see in the right columns the incidence of IPV for the past year as well. Next slide. So the prevalence, we saw that in the previous slide, about 1 out of every 3 American women will experience IPV in her lifetime. And this is really, I think, been almost consistent in a lot of different studies. We see that through the whole lifespan, women are very commonly experiencing IPV. So it's, as health providers, I think we're very likely to encounter it. And I think, people say if we look for it, it'll be there. Basically, I think most of the research on IPV prevalence has been done by emergency rooms because I see a lot of women with injuries. And most of the studies will say that up to 1/3 of women who come into the emergency room for injuries, it's an IPV-related source. So it's huge amount of IPV that emergency room physicians and personnel are seeing. I think for another sector of the healthcare providers that is seeing a lot of IPV is OBGYNs. And most recently, we've seen that IPV is a leading cause of female homicide. Maryland, I think, is one of the first states to actually do intensive surveillance on women who died during pregnancy or within the first year postpartum. And we were the first ones, I think, to find that homicide was the leading cause of death during pregnancy and postpartum. Ahead of, what we usually think of for people dying during pregnancy, it was ahead of hemorrhage, ahead of embolism, ahead of infection, all the typical things that we usually associate with maternal mortality. Homicide was way above that. And basically, we looked at 16 years worth of data in Maryland, and we found that homicide was the #1 leading cause. And not only that, intimate partner homicide accounted for 63% of those deaths. So here we have a huge factor, intimate partner violence being a cause of maternal mortality. Next slide. Looking at the prevalence of IPV, we see that if you just look at the woman's lifespan between birth and death, both IPV and depression, this is general depression, are most prevalent between menarche and menopause. So basically we're saying that the women of reproductive ages, really about ages 15 to 45, that they are the ones most likely affected by IPV and depression. The question is, here's the reproductive age group, and this is when women become pregnant, is what is the significance of pregnancy or the postpartum time on these conditions? Is one causative or a trigger for that? And we really don't know. Especially for depression, we've done a lot of studies on just whether the hormones would be causing the depression, and they haven't really found that. But there's no doubt that that reproductive age group is really high risk for both these conditions. Next slide, please. So what I'm going to do is kind of look at both these conditions together. And first I'll look at the postpartum depression part, which is on the left side of the screen. And we see that it's a really under-recognized condition. First of all, it's really not a medical condition as far as we think of it traditionally. So a lot of, there's no blood test that we can order for it. And it's not a diagnosis that's easy to come by. also, a lot of women don't feel that it's something that is out of the norm. So they almost feel that, you know, their depression is kind of goes you know, hand in hand with their pregnancy. They actually feel, oh, well, you know, I'm pregnant and I have all these hormone changes, and of course I'm going to be crying a lot and depressed. And even postpartum with a new baby, they feel like there's depression and crying spells, and being sad is kind of par for the course. But it really isn't, and you know, there's a lot of depression going on, and it's important to recognize the difference between what's normal and what's not normal. It's very, very underdiagnosed. So when we look at postpartum depression, a lot of providers are really not trained to really ask the right questions about depression. They don't know what to do if they have a positive screen, and they feel very uncomfortable doing this screening. So basically, we have very poor screening and counseling going on with postpartum depression, and this is even among OBGYNs. For the woman, I think there's a huge stigma with being admitting that she is depressed. Here we have one of the most happy times, supposedly, of her life, you know, having a new baby, being pregnant.
Okay, let's continue.
No, it's fine. So we were looking at the intersection between postpartum depression, perinatal depression, and IPV, and I think we're going into the next slide. We already established that, you know, they're all underrecognized, underdiagnosed, undertreated. So let's look at the prevalence, and basically we can see the prevalence for perinatal depression really varies quite a lot. It really depends on the definition that they're using, but we're actually seeing 9 to 11% during pregnancy and 7 to 13% during the first postpartum year. Some states have reported as high as 20%. But the confidence intervals, and that means, you know, the range in the prevalence is very, very high. So there's a high degree of uncertainty with these prevalences. And you can see why, because it's not a simple blood test. It depends on how they assess and how they screen. Oh, you know, my slide just went off again. Is everyone else having that problem? Okay, here I'm back. So with perinatal depression and perinatal IPV, we have almost the same thing, a wide range of variation in the prevalence, between 1 and 20% during pregnancy. And you can see why. It's because of the definitions and how much they routinely assess things. And most studies will say 48% during pregnancy, but most of the studies have been about physical violence. So here again, confidence intervals very high and a high degree of uncertainty. Next slide. The factors associated with postpartum perinatal depression and IPV. This is using our Maryland PRAMS data, which is a survey that we do postpartum of women who have recently delivered. It's a CDC project. And basically, we found that for both of them, it's the previous history of postpartum depression for the perinatal depression, and with the perinatal IPV, it's the previous history of IPV. But for both, maternal age less than 25 is at higher risk, being unhappy about the pregnancy, and this includes the partner or the woman herself. Both conditions have multiple stressors, either relationship stressors, financial stressors, traumatic stressors. Both are associated with cigarette smoking during pregnancy, binge drinking during pregnancy. With perinatal depression, we see that a history of IPV is actually a huge risk factor. And conversely, with perinatal IPV, we see the history of depression is a very, very big risk factor. So we can see the comorbidity between those two conditions very clearly there. Next slide. And who is at high risk? Well, for both these conditions, they occur among all demographic groups. There's no group that isn't involved, so there's no difference between whether we're talking about IPV or depression in terms of that they embrace socioeconomic groups, all of them, cultures, all different cultures, races, religions, sexual orientations, education levels, and for gender, for both of them, the female prevalence is much, much higher than the male prevalence. Next slide. And then the reason why I showed that last slide was because, since it involves so many different population groups, it's impossible to know who to screen and who to assess, because there's no difference really in if you actually just only screen people who you think are high risk, you're going to miss a significant part of the population that really does have these conditions. And so what we know about doing universal assessment is for, let's say, for perinatal depression, the majority of women don't mind being asked about this. And with a lot of studies, there's been about 5 or 6 studies, we know that at least 80% or more of women actually say that they're very comfortable with the screening. And the majority of women are not being asked, though. So we have the reason, I think, for most providers not doing the screening is that they feel uncomfortable with it, and they feel the women are uncomfortable being screened. But really, the majority of women don't mind it, and screening is not being done. We see that less than 50% are screened, and even of the ones who are screened, that only a minor segment of them, 22%, used a validated tool. So they're probably screening, saying that, oh, you know, are you depressed or you're not depressed, are you, that kind of thing, and not really a good screen at all. For IPV, we see the same situation exactly. The majority of women do not mind being asked about IPV. In fact, 90% or more are very comfortable with screening. And here we have again, the majority of women are not asked about it, are not assessed about IPV during their visits. We know that 10% in one report said that they were not even screened or had counseling by an OBGYN during their visits. Here again, it depends on what group you're talking to in terms of what population was the study was being done on. But I think the bottom line for both these conditions is that women don't mind being screened and that the majority are not being screened. Next slide. So for, I'm going to show you some data that we have from our PRAMS, and it just shows you I think the comorbidity with these two conditions. So we see here this chart, these are the women who reported depression, that if they had a history of IPV, almost 35% reported that they were depressed. Women who didn't have IPV, it was more like 11.9 to 12%. So there was 3 times the rate of depression among women with IPV versus women without IPV. And in our PRAMS survey, we actually could look at different factors associated with IPV. Being physically abused had the most prevalence of being depressed. 39% of women who were physically abused were depressed. The emotional part, the threatening or made to feel unsafe, 35% said they were depressed. Women who said that their activities were being controlled by their partners, 36% said that they were depressed. Women who were fighting for their safety or of their family, 33% said they were depressed. And even for sexual activities, 31% said they were depressed. And you can see there's still an overlap between these conditions. It's not just looking at conditions solely, but we see a huge amount of women being depressed if they had a history of IPV. Next slide. For postpartum depression, we looked at other things such as unhealthy behaviors. And we can see here also that postpartum depression was reported by 39% of women who were physically abused during pregnancy, more than any other unhealthy behavior, such as binge drinking, which is 37% of women who binge drank during pregnancy also had depression. 31% of women with late or no prenatal care were depressed. 25% of women who smoked during pregnancy were depressed, and our overall prevalence for depression was 14%. So those are really high-risk behaviors. But I want to point out that the abuse was the leading factor there associated with depression. Next slide. And if we look at stressors, we also see that physical abuse was the most common stressor associated with depression. Other things were jail time by the woman or her partner, being homeless, having a pregnancy that was unwanted by her partner, being separated or divorced during pregnancy, having unpaid bills, a job loss during pregnancy. All those were really significant for reporting depression, but here again, physical abuse was the most common cause associated with depression. Next slide. And now I want to look at actually the woman who reported abuse. And if we look at that, the condition that was most associated with a history of abuse was women who reported depression. 17% of women with depression had a history of abuse. And we can say the same with smoking during pregnancy, having no prenatal care, binge drinking during pregnancy. All were significant high-risk factors for being physically abused. So it doesn't mean it's not a cause and effect, but those are really strong associations. Next slide. And then we looked at stressors. This is the same, it's almost the same story. That's why they're so similar. So physical abuse before or during pregnancy was reported most by women who had a separation or divorce during their pregnancy, having a pregnancy who their partners didn't want, a job loss during pregnancy, jail time of themselves or their partners, or being homeless. You can see that both these conditions, they have a lot of stressors associated with them, and really the same sort of stressors too. Next slide. So basically, I think that the overlap between perinatal depression and perinatal intimate partner violence is very, very great, and that really we see the same kind of epidemiological groups having the risk factors, that it's common among all groups as well, and the association with a lot of the stressors is the same stressors is very, very common. Next slide. So basically, I think what's important here is that the Affordable Care Act reinforces what I've just really presented, that both depression and IPV are very common disorders and associated with unhealthy behaviors. I think we as healthcare providers really have a unique opportunity to assess and help these women. And the Affordable Care Act really, I think, just facilitates that for providers. As of September 23rd, 2010, it requires health insurers, including Medicare, to offer certain preventive health services free of copays for new health plans, and this includes depression screening as well as a lot of other different factors and disorders. In July of 2011, the Institute of Medicine came out with this huge statement saying that they recommended for women and adolescent girls screening and counseling for interpersonal and domestic violence in a culturally sensitive and supportive manner, so that they thought that this should be done routinely, that this is part of preventive health services. And this was huge because right after that, Secretary Sebelius said that starting with the first health coverage plan after August 2012, which is coming up very soon, that we would have complete insurance coverage without copays for intimate partner violence and domestic violence screening and counseling. And so this is really facilitates that whole encounter and discussion about this disorder. And they did it for several other things as well, such as STI counseling, well women visits, and contraceptive methods. Next slide. And just last month, ACOG came out with their committee opinion about intimate partner violence, and I think they reaffirmed that the position that really they thought that all women should be, during pregnancy, should be assessed for intimate partner violence during the first prenatal visit, each trimester, and postpartum. Next slide. So I'm going to line this up and say that, in summary, that both these conditions are under-recognized, under-diagnosed, and under-treated. They're both incredibly prevalent among the population of women that we see in Healthy Start. All demographic groups are affected, but especially those of reproductive age, and especially women under the ages of 25. Now, there's wide confidence intervals in these prevalences, and so we don't know the exact prevalence, but it's probably from 5 to 20% for both these conditions. It's associated with multiple stressors, including smoking, alcohol use, and unwanted pregnancies, and a huge comorbidity between perinatal depression and IPV. It's a shame that we have these conditions under-recognized and underdiagnosed and undertreated because they're actually very preventable. We know that women don't mind being screened, and there are multiple resources for both these conditions. We have very effective antidepressants for women, and there's multiple program services for intimate partner violence that we can refer them to. And I think, and this is the next talk, I believe, the impact on maternal and child health can therefore really be prevented as well. And that's, I think that ends my talk, and I think we can go on to the next talk for now. Thank you very much.
Thank you, Dr. Chang, for sticking with us and getting back, connected, and for your informative and interesting presentation. Our next speaker is Ms. Ife Udo. She's a third-year doctoral student of public health at Morgan State University in Baltimore. She completed her undergraduate studies in biochemistry in Nigeria. After college, she volunteered as an HIV/AIDS counselor in Nigeria and then relocated to the U.S. for graduate training. She's interested in gender and health, specifically the impact of intimate partner violence on maternal and child health outcomes. And she recently completed a year-long externship at Johns Hopkins School of Nursing under the mentorship of Dr. Phyllis Sharp. Ms. Udo?
Good evening, everybody. Thank you so much for this opportunity to talk about IPV and perinatal depression. I am going to be discussing three main researches. So I have three main studies that I'm just going to be talking about. And Dr. Chang had talked a lot about IPV and the definition, so I'm not going to really say much about the definitions, but she really gave a very good overview and details about what IPV and perinatal depression means. Am I going to do this myself, or you just, okay, you're advancing? So I'm not going to talk about the definition. She talked about physical, sexual, psychological, and I'm just going to move on to my first study, study one. The next slide, yes. So, as Dr. Chang has talked about, perinatal depression is, depression during pregnancy and or the first year of after pregnancy, which is postpartum. So what I tried to do in my slide was capture depression during pregnancy and what, research says about that, and then also capture depression and IPV after pregnancy and both. So this first study, the objective of this first study was to study the prevalence and risk factors associated with depression during pregnancy. The study was conducted in South Africa, and they had 1,062 pregnant women, and all of them were 18 years and over. They measured depression using the Edinburgh Depression Scale, which is a well-validated scale for measuring depression. And usually when you have a cutoff of 13 and over, then it says that there's depression. The mode of data collection was basically through interview. Next slide, please. And so they collected other kinds of information like the age, social support, cigarette and alcohol use during pregnancy, parity, which really talks about how many live births the women had had in the past, education, and they also looked at, asked them about violence in the previous year, which is IPV. Next slide. So the results of their study was that they found out that women that had reported previous year intimate partner violence were more likely to experience perinatal depression when you compare them to women who did not report past year violence. So those women were almost twice more likely. Women who reported IPV during the past year were more likely, more than almost two times more likely than their other counterparts to experience perinatal depression. So all of these factors that they had also looked at was age, income, and support. So, and support here was, support from partners. So they also found that, women that were younger were more likely to have experienced perinatal depression. Women with low income were more likely, and women who did not have support from their partners were also more likely to experience perinatal depression. Next slide. And so study really looks at perinatal depression or depression during and after pregnancy. So that kind of covers the whole continuum. And the objective of this second study was to assess the impact of IPV on the course of perinatal depression. They also took in consideration the effects of protective and risk factors. So they were looking at if these women had support or did not have support, or if they had other issues relating to trauma other than IPV. They took their data at 4 time points. So they looked at while they were pregnant, they looked at 3 months after delivery, 7 months after delivery, and then they also did 13 months after delivery. And the study was conducted in the United States, in Los Angeles. And they had 210 Latina women. And what they did was they just collected all those demographic information, they collected information about IPV, when you were exposed to IPV or not. And then at the end of it all, they kind of looked at the women who were exposed versus the women who were not exposed. Next slide, please. So as I mentioned before, they had interviews at all of the 4 time periods. They also measured depression using the birth inventory screen, and this is another kind of validated screener for depression. And for them, if a woman scored, had a score that was greater than 4, the woman was said to be depressed. And then they measured IPV using something called the abuse assessment screener, which is also a well-validated screening tool for IPV. Next screen. And with all, like other researchers, when you're doing conductive research, you want to also take information on demographics. So they looked at age, birth, income, employment, how many children they had in the past, the education, and the status of their relationship. Next slide, please. And so when they looked at all the information they had collected on those women, they looked at those who said that they had experienced violence versus those who did not experience violence. And what the findings were was that, number one, they found out that both prenatal and postnatal depression was present in both groups. So for the group that experienced IPV and the group that did not experience IPV, they found out there was depression. They also found out that depression was highest in the prenatal period. So for the group that had IPV, they were twice more likely to have experienced depression than the group that did not report IPV. They also found out that for both groups, depression was lowest in the 3 months following delivery. But just looking at the group that said that they had experienced IPV, they had significantly higher depression scores at each time point. The scores were way greater than the scores of those women who did not report any experience of IPV. And they were either at the cutoff or above the cutoff for depression. They also had higher cases of persistent depression scores. So just looking at those women across all the 4 time points, the women that had experienced IPV had consistently higher depression scores that was more than the cutoff on at least 2 or 3 times during the 4 time points. So depression was indeed more prevalent for women who reported IPV than women who did not report IPV. Next slide, please. So with this third study, I also was trying to demonstrate that IPV and depression can also take place after the woman had delivered, which is postpartum. Next slide, please. So this third study was looking at the relationship between IPV. So the third one was looking at the relationship between IPV during pregnancy and health outcomes for mother and child postpartum. So they looked at IPV during pregnancy and looked at how that was correlated with IPV postpartum. And the study was conducted in 20 cities in the United States. The participants were about 3,691 mothers, and they basically collected their information through interviews. Next slide, please. They also collected a couple demographic data. So they looked at race, age, education, relationship status, and family structure, and parity. Next slide. And one of the things that they found out was that both physical and emotional victimization was significantly increased for those who had experienced IPV. So IPV was, physical and emotional IPV was highly correlated with depression at 15 months follow-up. They also found out that depression scores were higher for women who experienced IPV alone and for women who experienced a combination of IPV and emotional violence as compared to just women who did not experience both of them. So the message to take away from this third study was that IPV and physical IPV and emotional IPV, when occurring together, predicted depression at 15 months more than just having emotional violence by itself. And then lastly, that depression scores were lowest for women that have experienced emotional violence by itself. Next slide, please. Among what they found out, they also found out that married women were less likely to develop depression, and that women who were having their very first child were less likely than women who had had much more children in the past to experience depression. Next slide. So with that, I'm concluding by saying that IPV is a great public health problem. It's associated with depression before, during, and after pregnancy. Women depressed during pregnancy enter prenatal care late. Depression during pregnancy negatively impacts attachment between mother and fetus and infants. And this basically leads to problems with cognitive, social, psychological, and behavioral well-being. And with that, that concludes my part.
Thank you, Ms. Udo. Thanks to both of our guest speakers. We'll be opening it up in a few minutes towards the end of the webinar for any questions or comments that you have. But we'd like to take a few minutes to introduce you to the work that's been going on over the last year and a half related to the HRSA IPV PD Resource Development Project. So I'll take a few moments to kind of give you all some of the background. This activity flow chart shows how each step has informed the next over the course of the last year. And the project came about because of a noted need and interest by HRSA to better address the intersection between IPV and PD. And this was, of course, supported by the research that we heard about that was coming out to support this connection. Throughout the project, we've actually changed the language to focus on perinatal depression instead of just postpartum in order to encompass the time before, during, and after pregnancy. So we started by pulling together a group of experts from around the country and from a variety of avenues, including federal employees, community organizations, researchers, nonprofits, and advocates. And we discussed current practices, research, and issues surrounding intimate partner violence and perinatal depression. You can see we then did a comprehensive lit review where we looked at prevalence rates and the intersection. We looked at policies and screening tools. And from there, we conducted a needs assessment with a random selection of Title V and Healthy Start programs. And some of you on the webinar today might have participated in that with us. We talked to 22 programs. And during this needs assessment, we were really looking to gather information on what Healthy Start and state Title V programs were already doing around intimate partner violence and perinatal depression. And we wanted to sort of assess their current resources and then identify and prioritize gaps that were out there in resources and in their capacities for prevention, screening, and treatment. And then all of this work together influenced our strategic plan moving forward. We held a second expert work group meeting where we began mapping out our plan for resource development. Currently, we are creating the toolkit, which I'll discuss in a few minutes, and we'll be piloting this with a random selection of Healthy Start programs beginning this fall. So we may be reaching out to some of you later this fall to look more closely at this toolkit. This diagram just shows you the overall approach that we took to resource development, which we called the integrated comprehensive tiered approach. So at the base of the diagram, we identified promising practices and existing resources. And then as part of this approach, and we've included in our toolkit, sections on policy and raising awareness and building partnerships. This is just another way to diagram how we laid out our tiered approach process. You'll notice that in this slide we list out some of the contextual factors, which we mainly got from the literature review, from our experts, and then from our needs assessment with you. So some of those, these are the things that influence the work that we're trying to do, and in turn the work that we do can influence these factors. So stigma was, of course, a huge one that kept coming up in terms of the stigma associated with perinatal depression and intimate partner violence. We heard about, that maybe this co-occurrence problem wasn't, didn't exist. We heard about competing priorities or lack of leadership support for this area. So this is just a model, again, for how we moved forward with our resource development. The toolkit we're creating is really a comprehensive guide. It's culturally and linguistically appropriate to help support community-based programs. It helps to make the case for why it's important to address intimate partner violence and perinatal depression as co-occurring conditions. It will assist communities in reducing stigma and provide strategies for building partnerships and increasing support from your leadership. And then the overall arching goal, obviously, is that we be improving the health and safety of families experiencing intimate partner violence and perinatal depression. So these are the main contents of the toolkit, which is, again, currently being created. And for each of these topics, we'll be holding upcoming webinars throughout the spring and summer to introduce you to the topic and kind of get into it a little more in depth. But the toolkit is made to be really easy to use and read with bullet points and tips and examples, and then some tools that will accompany the different sections that you can use and adapt for your program. So to start off, there's an assessing if you are ready, which is a short section which provides you with tips and tools to assess where you currently are and being able to address IPV and PD, and then help you to identify what resources do you have, what staff and skills do you already have, and what may you need to go out and get through partnerships to help you address IPV and PD. There's a making the case section, which gives you background information on the issues. This is particularly helpful if you're trying to just learn more about the topic, or you need some information and statistics that you can use to make the case to partners or leaders, or to raise awareness in your own community. And then that's followed by a raising awareness section, which kind of gives you specific steps and tips for how to raise awareness in your community, or even just among your own staff that you work with. And then there's cultural competency, where we look at the cultural and linguistic challenges or barriers that many of you face, and how to incorporate cultural competency into your program and into your screening techniques, things like that. The partnership section will give you concrete information for why partnerships are so important, how you can use them. We look a lot at non-traditional partners that you might not have thought about for reaching out to, and then some tips for how to reach out and build those partnerships. We also have information on current policies that are out there which are addressing IPV and PD. And then finally a standards of care section which looks at recommendations and guidelines provided by national organizations like ACOG or AAP, Futures Without Violence, and others. So it will provide you with links and additional information. So I know we went through this section rather quickly, but I just wanted to introduce you briefly to the project and what's ahead, and then let you know that you'll have opportunities to get more in depth with each of these topics on upcoming webinars. I'd like to open it up to any questions or comments that you might have to our guest speakers or to myself about the Resource Development Project. If you click on the little raise your hand feature, we'll be able to see if you have a question or comment, and we'll try to go in order. And again, if you have more in-depth comments or questions, feel free to email or call or leave us a message in the chat feature. So I see Marie Chastain has a comment. You need to enter your audio pin first, and then we can listen. Okay, it looks like we don't have any questions right now. Keisha, do you have any?
Yes, I do. Thank you. Thank you, Dr. Chang and also Ms. Udo, for your presentation and really highlighting the importance of looking at the intersection of intimate partner violence and perinatal depression. And I noticed throughout your presentations that factors are really the key factors that underlying role in connecting IPV with perinatal depression, stressors such as job loss or unwanted pregnancies and things like that. Is there a tool available to measure those, to measure stress and stress levels, some type of evidence-based tool that's available that's easily adaptable to community-based programs and that are culturally and linguistically appropriate for the population that Healthy Start program serves? And I direct that to either of the panelists.
This is Diana Chang. Well, there's really not a validated tool to ask about those questions, but I don't think there necessarily needs to be one. You can really just ask someone, is your partner supportive of the pregnancy? Was this an unplanned pregnancy? Do you have financial problems, things like that, and you can almost get a sense of their stressors. So it's perfectly okay to ask that.
Okay.
Yes, and this is easy. That's the same thing here. There's I don't know of any validated tool for that, but I know that from past research, they would just ask regular questions like, tell me, just to kind of get the feeling of their perceived stress, what they think might be stressing them out at any point in time during pregnancy or even after pregnancy.
Thank you.
We had a question from Jerry Michael. Jerry, are you there?
Yes, but I don't think I can talk.
Oh, we can hear you.
Oh, excellent. We were wondering if it is possible to get a list of references that were in the presentations as they were below where we could see on the screen.
Oh, yes, we can send that out.
That would be really helpful. And I was just kind of curious about the response to the last question. We're implementing a mental health, a maternal mental health initiative in our region in conjunction with our Healthy Start initiative, and working quite careful about the screening tools that we're using so that we can make sure that we're comparing basically apples and apples and oranges, so that we don't get a lot of, well, so that we have something that we might be able to validate in the future as we move through this new initiative. So I was a little curious about the fact that there was no recommendation for a tool that you might use around cultural competency, because we had one validated for our area specifically for depression.
Well, I know that Dr. Highsmith might be able to speak more about this from HRSA's point of view. Within the toolkit, we do have a section where, you know, we're not telling you which tool you should use and what's best, but we do have a list of some validated screening tools and what specifically they measure, so that it's kind of an easy chart for you to look and find what might be best for your population. Dr. Highsmith, do you have anything to add about the screening tools?
No, you know, we will provide a listing of some tools available, but my question was tailored more on trying to measure those stressors, and I do understand that there is a need to utilize validated measures so you are able to assess your findings with other research findings as well. But no, the purpose of our toolkit is to help direct Healthy Start projects and perhaps even State Title V programs in the right direction to identify those tools, and then perhaps adapt them to what they would like, to the population that they're serving, so it could be appropriate.
So I think within the toolkit you will see some information about some of the screening tools out there, but we aren't making a specific recommendation on what exactly you should use, because it will depend on your needs.
Okay, are there more questions?
Will there be information available at the conference this month?
Information available regarding the toolkit?
And what is the anticipated release date?
The toolkit is still being developed. I'm sorry, this is Keisha Highsmith. The toolkit is still, we're using this year to develop the toolkit, and it will not be available for use or to share until, well, next fall is when we plan to pilot the tool with a select few Healthy Start projects. So that is when, you know, we will hold a webinar to introduce the different sections in more detail. But a date for the actual tool release, I don't have that at this moment.
Thank you.
You're welcome.
See any other questions? If you do, please feel free to email us or call us if you think of something down the line, and we're happy to answer your questions or direct you towards other resources.
Okay, and thank you all for joining us today on this webcast.